webinar series on new tools for RNs in primary care. Judith Schaefer, Director of the LEAP Learning Community. Primary care teams learning from effective ambulatory practices, or LEAP, is a national program of the Robert Wood Johnson Foundation located at the McCall Center for Healthcare Innovation. Today, we're going to hear from registered nurses from 3 LEAP sites about how they have expanded their roles to optimize the utilization of the skills and clinical training of RNs. But before that, I'd like to encourage you all to actively use the chat boxes located on your screen. Please ask questions or make comments that the moderators may then pose at the end of the presentation. To see the chat box, you may have to move your cursor to the real extreme top of your computer screen and click on the chat icon that will appear there. The chat box, note the send to line. If you click on the downward arrow to display the menu, please scroll down and select all attendees so that everyone can see your questions and comments. We're this webinar, and we're going to post it on the PCT LEAP Commons website very soon after today's session. And we'll do our very best to make sure that the questions that you pose are answered within the context of the webinar, but if they're not, we'll have the ability to have a conversation about them on the Commons. Slide, Donna. From the agenda that we will hear from 2 presenters. We will hear from Bernadette Thomas, who is the Chief of Nursing at Community Health Centers, Inc. in Middletown, Connecticut. From Jackie Cobb from Eastern Oregon Medical Associates in Baker City, Oregon. We'll hear Molly Stevens, who is a registered nurse at Martins Point Health in Bangor, Maine. Also received a wonderful opportunity to hear a little about a medication protocol nursing role at Harvard Vanguard. So we're going to slip in some comments from Alice Smith during one of the question and answer sections. So with us now. Amy, would you like to begin with your introductory comments, and then we'll begin our webinar?
Thanks, Judith. This is Amy Hardy. I'm nurse manager at Central City Concerns, Old Town in Portland, Oregon. A happy Nurses Week to all of you nurses out there on the call. And also say I'm very excited about this discussion today. We'll be learning a lot about patients in nursing roles, from traditional nurse triage, med admin, nurse visits by delegation, utilizing a lot of expanded scope, protected time, standing orders, and new visit models like co-visits to empower the nurses to provide the best quality of care. So I'm excited to hear more from all of our presenters.
Ed is in, Amy.
Am I there?
You're there. Sorry, Ed. That's right.
Nice to join all of you. And the other thing I want to say is that as we visited the 30 LEAP sites, we're struck, number one, by how diverse the roles of nurses were, and which I think reflects some general uncertainty in the field about the best way to use these highly skilled professionals. So the topic, I think, is a critical issue for LEAP and a place where LEAP sites can make a major contribution. So without further ado, I'd like to hear from the LEAP sites. So
There is Bernadette Thomas, who's the Chief Nursing Officer at Community Health Center, Inc. in Connecticut. So, go ahead, Bernadette.
Good afternoon, everyone. So I've am pleased to present our role of nursing here at the Community Health Center. I'm representing all of our nurses. We have nearly 50 of them. Community Health Center is a network of community health centers across the state of Connecticut, and we serve people from nearly every town in the state. And we think that we're innovative because we really provide an expanded scope of nursing practice, not just through direct patient care and clinical care, but really investing in our nursing staff, either in managerial roles, quality improvement roles, or leadership roles. And I'm sorry, we should have advanced to the next slide. I'll do better for the next one. So I'm really going to go into more detail about the different roles that our nurses play here at the Community Health Center on the next slide to really answer the question about what is innovative about the primary care nurse role at the Community Health Center. On the next slide. I'll give you a chance. Perfect. Okay, great. So the nurses really have a dynamic roles here. A bulk of our nursing staff are what we call primary care nurses, but we do have some nurses who have dedicated roles either in nurse triage, which is a centralized system for managing our large call volume on a day-to-day basis. We have nurses who work with special populations, including hepatitis C, HIV, Suboxone, and healthcare for the homeless programs, and then nurses dedicated to our early detection program and in a patient assistance program, ensuring that our patients who otherwise could not access medications can access them. We have nurses who are dedicated to quality improvement through our Weitzman Center, and then we also have nurses who are content experts for Joint Commission because we are a Joint Commission accredited organization. So that's the bulk of our nurses work in primary care. On our next slide, how they really enhance care delivery in numerous ways through either delegated nursing visits. So after a provider sees a patient, they might write an order in that progress note to follow up with the nurse for a specific issue like wound care, like self-management goals. But we also have a large menu of independent nursing visits by standing order and by protocol, and it's probably 20 in number at this point, but it includes anticoagulation management, hypertension management, basal insulin titration, retinopathy, pupil dilation, of course, immunizations, Depo-Provera, emergency contraception, uncomplicated UTI, uncomplicated vulvovaginitis, pregnancy testing and diagnosis, and there's more on the list, but I won't waste my time telling you all of them. But I will say that the protocols are pretty complex and do include a number of them sending medications to the pharmacy and making complex treatment decisions based upon evidence-based algorithms. The nurses also all rotate on our nurse triage line. Even though we do have one dedicated nurse there, they rotate through, and triage is done through standing order. We use a Briggs manual to do our telephone triage. Panel management is a way that we've really incorporated team-based, the nurse into team-based care. So we do use dashboards at the Community Health Center, and there's dedicated time when the provider, nurse, and medical assistants sit down together and proactively look at the panel of patients by disease and see what type of additional care they might need or if they haven't been into the office lately. This is also the cornerstone of our abnormal cancer screening process, which was a direct outcome of a root cause analysis, a bad outcome when a patient did not receive abnormal cancer results. And now our nurses are part of this system where they will notify a patient within 30 days of an abnormal result, ensure that they have appropriate follow-up within 60 days, and if necessary, see a specialist within 90 days of that abnormal test result. We also, our nurses participate. I had mentioned that there's a standing order for retinopathy visits, but we do telemedicine here at the Community Health Center. Our medical assistants take photos of the retina, and we send them to an ophthalmologist at Yale University. And our nurses play a part in these visits as well by doing self-management, goal setting, diabetic foot exams, and if necessary, insulin titration. So it's a pretty advanced and complex visit. Our nurses are also currently being retrained and retold to provide care coordination services as part of their current roles, really focusing on transition care as well as advanced disease management and patient self-care to meet patient-centered medical home goals and requirements. And of course, medication administration is a key part of the nurse's role here at the Community Health Center. Medical assistants are not able to administer medication in the state of Connecticut. And then importantly, we couldn't do it without them, but our nurses are also managers and supervisors at every site around the organization. As far as training and experience is concerned, half of our nurses have bachelor's degrees, but nearly half have other types of degrees. That's the next slide, including licensed practical nurses, associate's nurse, and hospital-prepared nurses. Interestingly, about our associates prepared nurses is nearly half of them have a bachelor's in another field. So we have a lot of nurses coming with a lot of other experience like engineering, health coaching, business backgrounds who have taken on nursing as a second career. So it's a really diverse nursing staff, and they do need a lot of additional training. We have a lot of ways in which we reach our nurses to provide them training. Some of it is very formal, didactic, classroom type setting. We do lunchtime webinars where we repeat courses twice during a week so that nurses can join when it's convenient for them. And they're short sessions. They're about 20 to 30 minutes where we discuss new protocols and clinical processes and go through how those processes have been integrated into the electronic health record. We have grand rounds formats as well where nurses are able to achieve continuing nursing education units to advance their own board certification or continuing education needs. And then, of course, our local nurse supervisors and managers do on-site hands-on training and education continuously for our nursing staff. And then finally, on the next slide, how does the nurse really participate within the team? And there's a number of ways that nurses are engaged in interprofessional collaborative practice here at the Community Health Center. We do have dedicated team time, which we call, because we think this is a team sport, we call them huddles, where we try to get together once or twice a day and look at the patients who are coming in for each session and really plan out their care. I'd already mentioned panel management, which is when we look at the dashboard of patients that are part of the team. We also have some block time available to our nurses. I don't have time to talk about it now, but we have a method of knowledge transfer called Project Echo, where people call in to a panel of experts and can discuss really complex patients who have complex diseases like HIV, hepatitis, or opiate addiction, and our nurses all participate in that type of learning format. The nurses have block time for care coordination. The managers all have some kind of block time, but it really varies site by site and what the nursing needs are at that site. And then those nurses who are involved in non-direct patient care, like the EDP program or Joint Commission, it's 100% of their role is really dedicated to that non-direct patient care, whatever it is they're participating in. So we really ask them to dedicate and focus all of their efforts on that special project that they're working for. So I'm happy to answer any questions, and I hope I've stayed within my 5-minute time frame.
Bernadette, you did, absolutely, and thank you so much for getting so much information in such a short presentation. We had a few questions come up on the chat window, and the first one was a request. I think people were really impressed by your list of standing visit types, and it looks like they would be interested in seeing that list written, and then, if possible, also the protocols. Is that something that would be possible to share?
Absolutely. And so if I could just say to add on to that question is that as we've made the nursing role more complex at the Community Health Center, we really had to think about how we onboard new nurses. We do get a lot of new graduates and nurses who come from other practice settings, and this concept of primary care nursing is totally new to them. So we've actually made a orientation checklist, which I can send out to the group. I can send it by way of you, and that you can forward it to the group, which actually shows you the type of training that the nurses receive when they're onboarded here. And it includes a list of nurse visits by standing order so that we can ensure that as we onboard new nurses, we actually get the opportunity to have them observe and do themselves these standing orders to make sure they're competent in each one.
Wonderful. I know I would be grateful to see onboarding documentation. And it looks like a few other questions coming in, some about the nitty-gritty of the nursing role. It's beautiful to hear what you guys are doing, and we're all wondering, how do you pay for this? What's your funding stream for your nursing staff?
That's a great question. We really struggle with that. Connecticut is a fee-for-service state, and because we are federally qualified health centers, we are a Medicaid shop primarily. We have a small proportion of Medicare patients, like I'm sure you all do. We're probably 20%, maybe even less Medicare, but primarily Medicaid. So it really is a fee-for-service driven model. And, I think it's keeping nurses as a part of our team is fundamental for us, and it's really important to us. So we really strive to make them a part of every team, and they really are. So it's just part of our overhead. The nursing salaries and nursing staff is part of what we consider medical expenses. And every year when we go through our budget process, maintaining that staffing level is a part of the process with determining how many visits do we need to see maintain this level of staffing and this level of services. So it's challenging in Connecticut, but it is a goal of ours to maintain staff level.
Great. Question about your organization from one of the audience members. How many patients do you guys have that you see at all of your sites combined?
Well, according to UDS, which if any of you come from federally qualified health centers, you know about it, we have over 80,000 active patients. That's the patients we've seen within the 12 months. If we look retrospectively over the past 3 years, so any patient that we've touched within the past 3 years, it's hundreds of thousands of patients. But by UDS measures, it's over 80,000.
Great for that. And there was also a request for pay scale. I'm not sure if that's something you'd be willing to share. I know I want to just give the disclaimer to the group that that's quite variable state by state. So
yes.
I'm not sure how to translate or if that'd be information to share.
Right. I mean, I think that I think Connecticut is probably high because we're in the Northeast, and I think generally salaries may be a little bit higher here. But I don't mind giving you the range at all. I think we try to stay competitive, and I think the audience can tell me if they think that we're competitive. But for new grads who have no experience with nursing, we bring them in close to $30 an hour, so high $20 an hour. And then it ranges all the way up to the high $40 an hour for very experienced managerial level nurses. So the range is large for our nursing staff, and we think that it's very competitive. We hope, yeah.
And I thought that's fairly comparable to what we're doing here in the Northwest, just for the group to know. And I had some questions. I know time, but I have one quick one. Do you have a dedicated role to creating your training materials?
So the Community Health Center made a big investment in me a couple of years ago and created a chief nursing officer position. And it was one of the, I actually created the job description and proposed the job to Margaret Flinter and Mark Maselli, and said yes. And it was because, I've been a primary care provider here since 2005, and I really recognized watching nursing role change in our organization is that they really needed somebody to make sure that the nurses had the education and training they needed to adapt and adopt this changing, ever-changing role for primary care nurses. So that is a part of my job, is to these training materials.
Thank you so much for that.
You're welcome.
Ask a quick question, Bernadette.
Go for it, Ed.
Of that impressive list of nurse functions, which of those functions are done by the nurse assigned to a provider team, and which are done centrally?
The only things that are done centrally are nurse triage, the early detection program, assistance is central. But the bulk of the nursing services, which are delivered by primary care nurses, those nurses are empaneled. So they are assigned to primary care providers, and their panel is the provider's panel. So the majority of our nurses are empaneled.
Terrific. Thanks so much.
You're welcome.
Great. Do you have any other questions, Ed?
No.
So we can move on to our next presenter. Thanks again, Ed, and thanks to the group for all your great questions. Feel free to keep sending those through the chat window throughout the next presentation. We have Jackie Cobb, who's an RN at St. Luke's Clinic at Eastern Oregon Medical Associates, and her role there is an oncologic nurse navigator. Take it away, Jackie.
Okay, everyone, my name's Jackie. I'm a rural general oncology nurse navigator. That's a mouthful. In Baker City, Oregon. I wanted to start with a quote. It's a beautiful thing when a career and a passion come together. I love being a nurse, and I feel very privileged to have the opportunity to talk to you today about my passion that also happens to be a job. Geography. Baker City is located in eastern Oregon, about 2 hours from the Idaho border. Population in the city proper is 10,000 people. The county has 16,000 people covering 3,068 square miles. Go to the next slide, please. Okay. My unique RN role is assisting cancer patients through their cancer journey. I created this program a little over a year ago. I'm co-located at St. Luke's Eastern Oregon Medical Associates and work with 11 primary care physicians. If there has a patient that he suspects may have cancer or has had a positive biopsy result, he and I work together to form the next steps for that patient. I'll visit with the provider and patient. The provider gives the patient the diagnosis, and I take it from there, assessing the patient needs, support system, level of understanding, etc. From initial contact with the patient, I am their resource. We work together on everything from questions to ask the next doctor, transport into appointments, education of family members. I check on them after testing, surgery, or doctor's appointments. Keep the primary care provider updated as the process unfolds and help coordinate conversations between specialists and the primary care providers. Next slide, please. Faceted, I navigate, infuse, anticoagulate, and also complete co-visits with the a nurse practitioner that flies in from Boise. The facet of my job, I work with very diverse medical systems, and I also work with the people within those facilities. Next. I have various people that I work with. If I'm needed for a co-visit when a diagnosis is given, I flex my time to assure that it works for all parties. I also have the option of scheduling the patients I see in my roles to fit those that I navigate. Next, please. Navigated through the cancer journey, they have direct contact to me for questions. From trust that the patient is moved through the process without having to repeat testing or having missed steps. They have a line of direct communication if needed for the specific specialist. Let's see, go ahead and go to the next slide, sorry. That's the hard part, is keeping track of it all. So along the way, Mountain Tumor Institute started flying an oncologist out. I have a background in cancer care that started when I worked in an endoscopy lab. It was here that, for the time, I actually had the opportunity to see cancer. Seeing cancer in all its ugly forms really gave me a basis for me to build on my understanding of what cancer is. I then began splitting my time between the endoscopy lab and outpatient oncology treatment, becoming a nurse that then treated those cancers I had seen. From the outpatient oncology setting, I moved to Baker City, where no cancer services existed. I had a specialized skill set for oncology, but no outlet for those skills. However, I was hired by this wonderful family practice, Eastern Oregon Medical, to be a staff registered nurse. As a whole new skill set of family medicine, I continued to look for opportunities to use my oncology background. 3 years ago, Mountain States Tumor Institute, or MISTY, began flying in an oncologist once a month. This is my partnership with MISTY began. I'm here today talking to you about how I have a chance to use my family practice skills and my oncology skills every day. I worked with all the primary care providers in the staff nurse role, allowing me to build trusting relationships with all of them. Next slide. Doctors say to me, I don't even know where to start with a patient that has cancer. I don't know if they need a surgeon, an oncologist, or further testing. That's why I punt them to you. I take care of the patient and make sure they go where they need to go. In some cases, the medical assistants will say, do you know that this patient had cancer? I don't know what to tell them about the labs they need. Can you call them? So these patients that have a new diagnosis that I work with, it just depends on how the team decides to incorporate me in that role. However, I have the flexibility to accommodate the needs of the patient by scheduling other patients accordingly. Next. Home improvement, I'll touch on that really quickly. It's something I really enjoy. We've looked at colon cancer and have found that we've dropped the time in Navigator. Without a Navigator, we were at 64 days, and since I became involved, we've dropped that time from diagnosis to treatment to 30 days, so it's dropped time for these patients in half, so that's really exciting. I want to look at the statistics and figure out if our urban patients have a quicker time to treatment, and hope to set that bar higher for myself. So in conclusion, I've had an amazing opportunity to create a program that addresses the specific needs of cancer patients in our rural area. I work outside of the typical family practice role. Taking patients from diagnosis through treatment and onto hospice is the most rewarding job I have ever done. The fact that I have the opportunity to combine my family practice and oncology background. Questions?
Thank you. We have a question from Jamaica, and it is, how do the MAs assist your role? They contact the patient or help out with the education at all?
I would say that they definitely assist me. I work directly with one MA who is the patient of me if I'm not here. So she'll reach out to those patients, help coordination of transportation, etc. Usually the education is left to me, in I would say 90% of the cases. It's rare that she'll do all the education, but she's a big part of my success, I would say.
Wonderful. Ed, do you have any questions for Jackie?
As you know, because I visited you, I've never seen anybody in primary care play quite the role you play. Do you see that navigation role expanding beyond cancer?
I do. I feel like we've identified that if you can start with the patient at diagnosis and carry them through whatever process that is, if it's congestive heart failure, let's say, I think they can really see that having somebody that's a constant resource that's checking in on them helps them be more successful as they go down that road. I also think that it decreases the amount of time that the primary care provider has to be involved, as long as communicating on a regular interval with those physicians, they're not as much of the equation as they have been in the past.
So it really is management, but it's done really from the point of diagnosis rather than waiting for to really get into trouble.
That's what I really like about it. I had done care management prior to doing this role, and in care management, it felt like you got the patient when they were a mess, and you were trying really hard to get them straightened out as much as you could. And in this situation, it never gets to the point, I won't say never, but I do a lot of preventative involvement to make sure that we don't get to that messy point. And I think with a diagnosis, cancer can get really messy, but I think any time in our area, we send so many patients away from the primary care physician to specialties, it's really easy for things to get messy and complicated.
And you are also very aggressively coordinating care.
Right. So if I have a patient that has a probable lung cancer, I'm talking to that pulmonologist, getting the physician or the primary care provider in contact with that pulmonologist. They're discussing patient symptoms, and it really does smooth out that process where normally the pulmonologist would get a referral, then they try to fit them in their schedule. We really have closed some really big gaps in specialty care that for us at sometimes have been insurmountable.
Yeah.
Go ahead.
No, Ed.
No, go ahead, Amy.
I say I'm sure that providers working with patients with chronic conditions are just waiting for when they get to have nurse navigators help support their clients as well.
And it's because care management and nurse navigation, I've thought a lot about what the difference is. I think that navigation piece is truly begins at diagnosis. I think that's the key to the difference in the terminology. Is you are navigating a person through their disease process. You have a bit more to do education versus coordination.
Mm-hmm. Ed, do you have any more questions for Jackie, or are there any more questions from the? Oh, here's a question that just came in. Do you charge for the services you provide?
Not. My job was initially created through an NCCCP grant, and once that grant expired, then they absorbed me into the nursing budget. As you can see, my total hours per week that are dedicated or that end up being straight is 2 hours a week, so the hours are not a huge part of everything else that I do today, so it's just absorbed. They do ask me to block or set time aside so they can track how many hours are navigation specific. It all started with an NCCC grant.
Thanks. I have another question. Do any of the oncology specialty practices have navigators as well? And if so, how do you coordinate with them? And I would say, yeah, how do you coordinate with them?
So I think a perfect example is the navigation program for Mountain States Tumor Institute started with breast navigators. Those navigators, I still will take, if I get a new breast diagnosis, they go directly into the breast navigation system. So there are specialties that exist, but breast is the only specialty in the Mountain States Tumor Institute system or the St. Luke's system that's specific. I guess I take that back. There's also thoracic. There's a thoracic navigator, so I do work with her. The problem with lung cancer is we need PET scans and other scanning that needs to be done, and many times the amount of travel that needs to occur is very difficult, so I have to coordinate those services here in our local community. Thoracic navigator is really that person that will them when they go into Boise for something along those lines.
Okay, thank you. And one last question before we head over to Alice Smith from Harvard Vanguard about her med titration protocols. How long do you follow and /engage patients for their care? And is there a handoff at any point to any other navigators you were just discussing or different nurse coordinator role?
Yeah, it's a really great question because it's something that when I first developed the program, I was asked that a lot. Are you going to be a through navigator or a beginning navigator? And what I found in our rural community is through navigation is really the key. If I am a part of each step of their process, then when they do or need that step onto hospice, it's a really smooth transition. If I were just a part of their life in the beginning, I tried that in a few cases, and what I found is I got them lined up into the surgeon, figured that once they entered chemo or had treatment, things would be fine. But what I found is they were still reaching out to me, asking me questions or needing assistance from me. So stayed a part of the process all the way through. Everyone was more successful. So I've decided that the general rural navigator is definitely a through navigator. Because of the relationships that you build with a patient from that transition on to end of life care is really smooth and not nearly as troublesome as when they are taken off treatment and onto hospice, and it just doesn't flow as well. So that whole picture is really important, I think.
Great. Well, all of this information, your presentation, and those great answers for our Q&A section. And now I'd like to introduce Alice Smith from Harvard Vanguard. Alice, are you there?
Can you hear me?
Take it.
Okay. So my name is Alice Smith. I'm actually a staff nurse in internal medicine at Harvard Vanguard site in Medford, Massachusetts. We are part of Patient-Centered Medical Home, and I've enjoyed listening to the other presenters. But actually, I love your program that you have. A few years back, we really started to look at how the primary care nurse role in the internal medicine setting could make a difference. And we started as a hypertension medication protocol. It was an interdisciplinary group that developed this program. Nurses and physicians, the pharmacists, came together and developed specific missions to have the RNs titrate and follow up with patients, office visits, and also by phone, developing not only the protocol, but also nursing documentation, education materials that were standardized for everyone to use, as well as patient after visit summaries. It was quite successful. The patients definitely enjoyed it, and we saw an improvement in our quality scores. And we decided to integrate diabetes management and lipid management as well, and have sort of added medications. So for hypertension, we use chlorothiazide, chlorthalidone, lisinopril, losartan, amlodipine, Avapro. For diabetes, we titrate metformin, glimepiride, Lantus, and actually we're now looking at an analog protocol. All the lipid medications that you could sort of wish wish for. Site has been quite successful. We enrolled in 2012 869 people. Showed an improvement in A1C scores from 8.7 for the A1C at the start to 8.1 in 3 months to 8 at 6 months. And, saw improvements as well for hypertension and for hyperlipidemia as well. So when I was listening to Bernadette, we developed a weekly huddle with the PCP where the RN meets with the PCP team member, and we actually go ahead and go through each patient that maybe had pressure 6 weeks ago that was missed and was elevated. We make a decision if that person needs to come in and see the nurse or the clinician. If the person's already enrolled, we actually go through and come up with the next step plan if it's outside of the protocol. Determine if that person could also benefit from the other resources that we have here. Our nutritionist, we have a great health coach, our pharmacist as well. So, and a wonderful role. So I don't know. Want to take much time? I don't know. Much more time there is.
For the quick summary of the work that you all are doing at Harvard, Vanguard, and Medford, we see some requests for any more information about the work you're doing. Folks love the slides. And so if you have any sort of summary or reference or guiding documents that you can share with LEAP and we can post on the LEAP site or share with the attendees of this webinar, it sounds like there'd be interest in that, including the protocols themselves.
We'd be happy to check that out and see if we can get permission to do so. I'd be happy to do that and share it. We actually are share it with the other Atria sites now, as well as some of the outside contact.
I have a quick question for Alice before we proceed to Molly from Mark Point.
Just how much of your day is spent titrating medications and the rest of the day?
Certain. So actually, our rule, primarily, I would ideally, 50% of my day would be spent doing chronic disease management. When we started out, I said I left Boston hospitals doing the Band-Aid approach, acute crisis management, really good difference with public health, with people keeping well. So we did a lot of triage, we did a lot of post-discharge calls, we do emergency follow-up calls, management huddles. When access is an issue, demand management goes up, and so we're doing more triage. But I would say that probably 50% of my time I weave into the course of my day the chronic disease management.
Titration is a part.
Exactly, of which the medication titration is a part of it, yes. And we go in and see patients and meet them. The things actually have definitely gotten into the role of bringing us into the patient's room and introducing us, and that is, I think, one of the biggest successes, because really is the primary care team members, and we introduce ourselves as a team, and that, I think, has been really successful. People have definitely trusted us and developed a rapport, so that often I believe we've really been able to keep people at the hospital, in part because of that primary nurse role that we've developed.
Do you have independent nurse visits?
We actually will see people and follow up. So for our hypertension protocol, we actually follow up at the 1 month mark. Depending on the medication that they're on, if they need labs, we'll be checking in at 2 weeks, is what we have for our protocols, mainly for the people that need blood work. So we will actually bring them into the office and do a follow-up visit and teaching, and sort of work on some of the other risk factors that are contributors for tension or for diabetes, working on motivational interviewing, things like that. We also have telephone appointments that we set up for contact and follow up. Follow them until we get them to goal.
Thank you so much.
Thank you.
No,
We're all very grateful.
I was thanking her. Go ahead, Amy.
I was thanking her. We're all very grateful. Thanks for sharing the information. And our last presenter is Molly Stevens, who's a nurse at Martins Point Healthcare in Bangor, Maine. Take it away, Molly.
Thank you. I'm thrilled to participate today, although my voice may sound a little bit like I'm a 4-pack-a-day smoker. I honestly am not. I've been laryngitis, so bear with me. Next slide, please. In my favorite topics, I really love what I've heard so far from all the speakers today. In 3 providers, we have 3 RNs. And the primary role of the RN is to collaborate with providers to care for our most chronically ill patients. If you can imagine for a moment an office setting where patient service reps are trained to do triage and refill prescriptions using a standardized process and evidence-based protocols, and medical assistants are functioning as scribes in a team model, RNs are collaborating with providers to meet our most complex, unstable chronic disease patients, you'll have a pretty idea of how we roll here in Bangor, Maine. Next slide, please. Excuse me. Our collaborative care visits are based on a model developed by Dr. Ed Wagner, that he's on the call today, for care of chronic disease patients, and they're designed to provide a care team approach, much of what we've heard already by prior speakers, to provide additional clinical face time with the patient, for taking education and coaching, particularly when self-management is paramount for the success. The model enables the nurse really to have a longer visit, 60 minutes, which is spent with the collaborative care nurse. The nurse is engaged in the final phase of the visit, including the physical exam and update of the treatment plan, spends about 15 minutes of the visit. A huge part of the success of the visits relies on the coordination and pre-planning by the RN, including the pre-visit huddle that we've already heard about. Provider. During that time, we discuss treatment options, changes, lab results that need to be addressed with patients. This allows the nurse to go into the visit and basically review all those results with the patient, discuss treatment plans that have already been worked out with the provider. Perhaps we have a patient who needs to go on insulin. The nurse already talks about it with the patient. The dosing is already been discussed. So by the time the provider comes into the visit, the teaching that's been done, the insulin's been ordered, handouts might have been provided, and there's a plan for follow-up that's already been made. Sometimes it doesn't buy into the plan, so it may take several visits to coordinate and continue to plan with that patient. The RN also follows up with patients between visits and after hospital discharges if additional support is needed. Sometimes that means referrals to other agencies and community resources, so that's where our care management role comes in. Next slide, please. Yes, we have. Our diabetic patients in poor control who had collaborative visits outperformed those who were under the traditional care model in A1Cs, blood pressure, and LDL targets. Revenue, this helps pay for our nurses. We can have an increased RVU per provider per hour, and 15 minutes of provider time for a visit coded at a 99214, 99215. Costs have gone affected by going down by a lower per member per month cost for emergency department inpatient expenses, despite in our region having a higher cost of care overall. We use patient satisfaction through our high loyalty scores and retention rates, and certainly increased provider and RN satisfaction. Next, please. Right there. Our training program, well, we do have a training program for new people coming in, and as we entered these roles as nurses, we came in with various experience. I was certified in another lifetime as a case manager. We have nurses who certified in geriatric nursing prior to coming in. We basically don't have nurses here who are right out of school. They're experienced nurses who come in with some background. we shared knowledge with each other. I took a 13-week course offered by Well Coaches on coaching, which focused on the evidence-based coaching skills, which are really exciting and a new field of research and study. We optimally use our electronic medical record to get that comprehensive view of the patient's health care. We realize that a very small portion of their care is provided within our walls. So we're fortunate in Maine to have an awesome health information exchange. We use it in our daily workflow to really keep up with what's going on with our patients, what other providers are they seeing, where have they been seen in the hospital emergency department, other consultants. It's an awesome tool that we use today in all our care. Right now, we don't have anyone certified in diabetes education, but that is a goal we're moving toward to make that population. And as we do work with these chronic disease patients, it kind of naturally flows into population management. We do take shots of how our overall population is doing, but by doing this work, it naturally improves our population management. We have education in coding. We continually work with our coding people, so we learn what documentation is needed, the way we get paid for the excellent and complex work that we're providing. And have an ongoing process where we continually review how we're doing. We meet every 2 weeks, friends and providers. We are so fortunate to have providers that are generous in sharing their knowledge with us. As we say in Maine, it's wicked cool that our culture here supports equality and open exchange of ideas and suggestions. We're just so fortunate to operate on a high level of trust and respect, which I think makes the program really work. Now, please. Has her own schedule of patients, which is shared with the provider for the collaborative visits. We do have some time blocked to do some administrative tasks and follow up with patients. Other responsibilities, we do independent nurse visits for anticoagulation therapy management. Liaison with our community care team and patient-centered medical home. We do follow-up calls on patients who were discharged from the hospitals and just participate on teams within the organization, both locally and our bigger organization of Maine, Martins Point Healthcare in Maine, to work evaluating and developing processes. We also do some Medicare wellness visits independently. Subsequent visits can be done independently. So that concludes my talk. Thank you very much.
Molly, much. We have quite a few questions from the audience, and some of them are around the protocols that you use and just interested in those. And then there are also questions about the staffing ratios provided to, or RN to providers. It also is all of the nurses' time paid or reimbursed by provider coding or by a different funding source?
We different funding source. We have to make sure that our budget is supporting the salaries, which it does with these collaborative visits. It does support it.
So,
RNs, 3 RNs of an office of 3 providers. We do have 1 opening right now for a provider. We're down 1. We have 3 RNs and we have 4 medical assistants.
Great meetings look like between the RNs and the providers. Is it kind of like a huddle?
It's a little different than a huddle. We have a wonderful practice manager and quality improvement person on our staff who basically help to set an agenda. We always have an agenda for a meeting. We follow some really great protocols to have the meeting ahead of time what we're going to be talking about. And we just kind of, things that come up, graduation, for example, from collaborative visits, we might talk about that. We might talk about how many people, do we have the appropriate mix or have we just been filling the schedules with warm bodies to prepare for patients? Sometimes that happens. We have a protocol for graduation program from the collaborative care program. So those are some of the topics we might discuss. I have a question about group visits, and we actually have talked about it. It's something on our radar screen. We'd love to do that. We haven't worked out the protocols yet, but it is something we would love to do.
Great. And so about Martin's Point itself, are you guys a private practice or an FQHC?
We are an FQHC, private practice, and we're not affiliated with any hospital or big kahuna kind of organization, which is kind of nice. We're not part of a hospital-based program.
Another question.
Maine. Yeah.
Great. Thanks. So I really appreciated all the outcomes that you shared with us, and a question about that is the increase in RVUs coming from the physicians being able to see more patients, or are they upping for the education that the RN is providing at the shared appointment?
A little bit of both. You figure if they see a patient, one of these complex patients in 30 minutes, they might be able to get the 214 out of that. But if they can see 2 214s in 30 minutes, if they see 4 of them in an hour, that really improves their RVUs, and that's how we see it working. We have RNs that will all be lined up with collaborative visits, and there might be one writer per each of us, but there might be one right after another for a provider who's going from to another and able to get those higher visits in with less of their time. Spend time on the upfront of it. Did spend time on the upfront where we had huddle and we had the discussion and we had the, the planning. So it's all package deal that works very, very well.
One last question, and then I'm going to hand it over to Ed in case he has any questions, and he'll jump into our wrap-up because we're running out of time, unfortunately. But does the RN assist the providers with data and charting chores? I'm not sure what dashboard back means. Maybe you know.
Maybe dashboard means looking at the population as a whole.
Yeah, probably.
Yeah. Excuse me. As time allows, we try to make sure people have follow-ups, and we look at the sickest patients and make sure that they're in our schedules. Charting, we stay for the entire visit. We drive for the provider when they come in. We do all the, many times we've got the orders all done before they come in. They can always have the option to change them or, of course, but we work so well together that we can often anticipate what the appropriate orders are. We take care of that. We do all the scribing for the visit. We set the visit to their inbox when we're finished so they can review it and ensure that they finalize the billing code and ensure that everything was done properly to their standard.
Thank you so much for your presentation and for your wonderful answers, and thanks again to all attendees for all of their really great questions throughout this whole presentation. I'm going to hand it over to Ed in case he has any questions, and then also for a little bit of an update on what's up next with the LEAP project.
And thank you to all 4 presenters. You were just terrific. In looking at the chat box, there's a lot of interest in the topic and in enabling people to talk to each other. And I just want to remind everybody on the call that's the whole purpose of PCT Leap Commons. And we've been a little disappointed with the level of participation and involvement in that website, and I'd just like to give it another reminder and hope that you'll participate there. Next steps for LEAP are, as I think you probably all remember, is that we have now coded all of the massive amount of information that we got on the site visits so that we can actually find things that we're looking for. We are in the process of creating a web-based technical assistance program based on all that you all have taught us. That'll hopefully, beginning later this year, we'll be disseminating to other learning communities that are supporting practices that are not LEAP practices, but more sort of middle of the road practices that are trying to get better, like you all are, and working with those learning communities to integrate our technical assistance program into their primary care transformation activities, and then we will be evaluating how successful and how useful this technical assistance is. The technical assistance, which hopefully we'll be able to share with you in a couple of months, you will recognize is capturing a lot of what you hear on these webinars. So it will hopefully be of interest to you as well as to the broader field. So the next step. I just want to say one last thing. I suspect you all noticed that Bernadette Thomas comes from a site that is not one of our LEAP sites, Community Health Centers, Inc. In Connecticut. The reason it's not is that it is the organization of our co-director, Dr. Margaret Flinter. And we agreed in the of this project that we would neither of us would include our own organizations among the LEAP sites. But as you heard from Bernadette, Community Health Center, Inc. has a lot of the characteristics of a LEAP site. So again, terrific conversation, wonderful presentations from our four presenters, and I'll turn it back to Judith.
This has been just a fantastic webinar, really appreciative. I'll just close by saying that thank you for your very well-articulated interest in continuing the conversation on LEAP Commons. Please go there and register if you haven't done so already. We'll start a thread that will help you easily identify where the conversation will be about this, following up on this webinar. And thank you again to our wonderful presenters and our moderator, today's moderator, who I forgot to introduce, from Amy Hardy from Central City Concerns. Thank you, everyone, and have a good day. Bye-bye.